Hello and welcome to Talk of Hope, a podcast for people affected by lung cancer. I'm Rachel Avery.
And I'm Mandy Lucas.
Each episode we'll hear from people with different experiences of lung cancer, as well as healthcare professionals who will share what's going on to improve the diagnosis and treatment of this disease.
And as someone who's had lung cancer, I know exactly how terrifying it can be. But amongst all that fear and anxiety, there is also hope. And that's what we're choosing to focus on here.
In recent years, our understanding of lung cancer has improved significantly, from the different types of the disease to the now many ways we can treat it. And our desire for knowledge continues, which is why we are proud to fund a new research project that aims to help us better understand young women and lung cancer. Staggeringly, women aged between 30 to 49 who have never smoked have more than twice the risk of developing lung cancer than their male counterparts. And yet this disease is still one that is so readily associated with men. Here to tell us more about the project and how it could develop potential strategies that improve diagnostic and survivorship care for young women is lead researcher Dr Cecilia Pompeli, Associate Professor and Thoracic Surgeon focusing on patient-reported outcomes research. Hi, Cecilia.
Hi. Nice to see you and nice to be here.
Thank you so much for joining us. I know Mandy is probably absolutely chomping at the bit about this podcast because, you know, as a young woman who was diagnosed with lung cancer, it's obviously very, very close to her heart, as it is a lot of our advocates, a lot of our listeners. And we as a charity are absolutely delighted to be funding this research because it is absolutely essential. We need better understanding of the links between younger women and lung cancer, don't we? Do you want to just start by giving us kind of setting the scene really of what the research project is and what it's hoping to achieve?
Of course. And again, of course, I want to start with a big thank you because this is a huge effort in trying to understand why a lot of women and again, young women are diagnosed with lung cancer at a later stage, unfortunately. So the focus of this research is to interview and ask some patients, so young women below the age of 55, about their experience of being diagnosed and also treated for lung cancer. But we are also focusing on all the diagnostic pathway because we are really interested to see how these women ended up in being diagnosed with lung cancer at different stages. And again, as I mentioned before, unfortunately, the statistics are saying that there is a delay in diagnosis for young women. And we're also looking at the experience of these women and potentially to the experience of their family members or their supporting person, as we call nowadays the carers around the women, because we are also used to have as carers more women. But in this case, we really would like to know how is the experience for example, a working mom or a working woman who has this striking diagnosis and has to stop working or has to, of course, divert her life into this new journey. And so because we are, again, more used to be the carers, how this is affecting the ones that are looking after them. So this will focus as well, again, on the main supporting people around the patient, and potentially we'll also would like to have some understanding from the healthcare professionals that are treating those patients. Because again, and this is coming probably from my personal experience, we've done a few years ago a study on quality of life, on patient-reported outcomes in people with early stage lung cancer. So you can imagine the average age was a little bit higher than this is in this this case. And I still remember that one of the patients who we interviewed, she was 44. And this interview was completely different from the one that I was used to have before. Or, of course, the patient that we're seeing in clinic, we are concentrating on asking some specific questions that are, for a surgeon, of course, related to the surgical, post-surgical effect and not a lot on quality of life. But because that study was about quality of life, she was referring about how different was the effect of a lung cancer diagnosis on her life. She had a very young family. And again, how difficult was for her to get a possible diagnosis. Fortunately, in that case, was an early stage. But again, I think that kind of experience made me feel that it's important also to ask from a patient perspective, how was the journey that ended in a diagnostic additional journey?
It is so important. Much of my role in the charity is working with patients and working with advocates and raising awareness and storytelling and sharing their experience. And far, far too often, particularly when I'm speaking to a younger patient, and it can be, female or male, but with women, there seems that there were missed opportunities to diagnose sooner. And I think particularly when you're throwing in, a younger person, a person that potentially doesn't have a smoking history. And I said in the intro, lung cancer is still, I feel anyway, seen as a male disease. As a man, you're more likely to get lung cancer. It's one of the cancers that I think is more readily associated with men than women, and certainly, or if it is women, it's older women. So that, someone who's my age, I'm 42, it just seems so improbable and unlikely. And obviously, the risk is low, but it is happening, and it seems to be happening more and more and more. So it's such an important piece of work.
I think the idea is definitely this low perceived likelihood of developing lung cancer for a young woman. And this is leading, unfortunately, to diagnostic delay, because there are even reports that are saying essentially that women are getting through the diagnostic pathway in a different pace, essentially. So they are getting more visits before having, for example, a chest X-ray, compared to, of course, a smoker or a patient who has family history of lung cancer, but a male patient. So these diagnostic delays are, I think, something that we can control a little bit better. Because again, as you said, the young women, the diagnostic rate, fortunately, are improving, but not as the other type of cancer, as breast cancer or other type. We have also the screening program, but of course, if you have not a history of smoking in the past, you are not contemplated into the screening criteria. And the same is for the age criteria, because we are talking about older patient. So I think that this perceived low likelihood of getting lung cancer should be modified, and raising awareness is the key, of course, from a patient perspective, but also for example, from the healthcare professionals as well. So that's the key thing. Another aspect, of course, and this has been reported elsewhere, is the stigma associated with lung cancer. So unfortunately, a lot of women are also, let's say, not very comfortable to think probably that they can get lung cancer, even if they didn't smoke. But unfortunately, there are other risk factors, and we need to make sure that if we are having some symptoms and those symptoms are prolonged or are not taken into consideration from the GP, we need to insist and make sure that we are doing all the possible tests to rule out, fortunately, this cancer diagnosis. But definitely is something that has been reported that women are getting more GP visit before having a proper test.
I don't know if you can answer this, but again, from interviewing younger women, I've spotted that quite a lot don't have kind of the expected symptoms, kind of the respiratory symptoms that people would perhaps more associate with lung cancer. So it could be that someone's having back pain or shoulder pain, or there was one lady, she had a lump in her neck. But a lot of them don't report a cough. So, you know, that awareness that we talk about that's so important, you know, awareness of symptoms is low anyway. You know, a study that we did last year found that I think it's only about 25% of people could name a single symptom, which is staggering considering how much we talk about symptoms and coughs and all of that. But those even more seemingly unconnected symptoms, are younger women more likely to exhibit those sorts of symptoms than potentially respiratory, or is it all just very, you know, person by person?
Unfortunately, because I would like to say these kind of symptoms are more associated, but unfortunately, there's no evidence to show that one symptom is more associated with a certain age range or a certain population. And this is unfortunately pretty much unique for lung cancer because the symptoms can be very specific. And we learned during COVID, because the lungs we are experiencing even after a bad cold, all the symptoms that potentially are very similar to the ones who are associated with lung cancer, is very hard to give this advice in terms, if you have this symptom associated with another symptom, just go to the GP and they will make a chest X-ray. Unfortunately, this is not possible. For young women, the only thing is that usually we are fitter, and so those symptoms can be shown at a later stage. Because again, and this is where the delay probably is coming from, because if we are having a cough, we are, of course, more keen to think that is a bad cold. And if I have never smoked, and so I would be the first one to say, okay, let's wait another couple of weeks before going to the GP.
Yeah. And women are busy. You know, you said
exactly
before about working mums and working women, and
exactly.
You know, it's not bang the feminist drum here, but I'm going to. You know, we are juggling a lot.
Exactly.
You know, it takes a lot to take time out of your day, to take time away from your family, your children, off work, to go to the doctors for something that, you know, you don't actually think is that important because it's November and I've got a cough, and why would I do that?
Exactly. That's why our, let's say, broader suggestion is always, if a persistent symptom, which is a respiratory symptom or something associated with weight loss or like pain, like you mentioned, some pain that you didn't have, if you're associating all these symptoms and these are persistent symptoms that are not going away after a few weeks, is always better to seek medical advice. And this is regardless age, gender, or our working environment. That's the main probably advice that we can give. And of course, the awareness, as I said, should be also from the healthcare professionals, because this is where, unfortunately, we are seeing some gaps. And again, we know that primary care is extremely busy, and they have now, we are fortunate to have within the NHS the lung cancer screening funded. So it's already a lot in terms of investment, but we really need to make sure that if a young woman is going to the GP for the third time with symptoms that are correlated to some respiratory issue and additional ones, and maybe correlated to genetic factors or some family history, to try to think earlier to a chest X-ray or a CT scan.
Do you think that's, I mean, I'm not GP bashing at all. They are general practitioners. They can't know everything about every illness, but there seems to be a lot of signs being missed. You know, you hear of younger women who've got a cough going to a GP and getting 3 or 4 different courses of antibiotics, and not even then being offered a chest X-ray. So is there an education piece that needs to be done for the general practitioners as well, who are, like you say, the first people that you'd see if you had a problem? I think a lot of things that come through from interviews that we've done before is, you know, your own body, and if something doesn't feel right, you go to the GP. You don't want to be told, oh, it's just a cough, or you might pulled a muscle in your back from the gym. You don't want to be told that. If you know that you don't feel right and it isn't just a muscle pull or a cough, unfortunately, people have to self-advocate, but some people aren't comfortable doing that. So wouldn't it be good if the GP just sent you for a chest X-ray at that point? I mean, I don't know whether that's a possible thing. I know that it's quite, I've been through that exact diagnosis, so I know how quick it is, but it's very hard to get to that point. And that's where we're seeing the late stage diagnosis, because it takes so long to even get into the hospital setting to have that X-ray, which won't diagnose you, but it will show that something's there that needs further investigation. So I always wonder where, and again, I'm not GP bashing at all. Our GPs are amazing. They do an incredible job, but it's almost like there's an awareness piece that it's not older people who smoked that are your only, what's the word I'm looking for? The only people who might have lung cancer. So how do you feel about that? Yeah.
I think this is absolutely true. And this is where even this small research wants to, let's say, boost this awareness at a broader level, because, of course, unfortunately, we cannot refer to chest X-ray every single person who's coming to a GP practice with a cough.
Yeah.
So we need, in any case, a triage method. But definitely what we understood from this recent is not only the research, but is also the numbers that are coming from the epidemiological studies or even the WHO maps, is that more young women are now diagnosed. There is for sure some kind of shift. And there are a lot of researchers that are investigating why. So it's not, unfortunately, it's not yet clear, as was the cigarette smoking in terms of risk factors. But still, we're having definitely more young women diagnosed overall. So it should be raised, this awareness on the primary care for sure, even A&E perspectives as well, that there should be some moment where even for a young woman, the GP should start thinking about referring for a chest X-ray. And we know how busy the hospitals are, the NHS is, and we know that chest X-ray can be very quick, but it's also important, again, to triage those kind of referrals. But I think that we are still missing a little bit of awareness. So I completely agree with you, Mandy, in terms of even these numbers that are out now, raising awareness in terms of the genetics behind or the numbers that are associated with lung cancer in young individuals. Because, again, I don't think that all the GPs are aware of those very specific numbers. And again, I think it's a very recent type of research at the moment. I'm very glad because even the last couple of weeks, couple of big reviews in the big journals have been published in terms of lung cancer in non-smokers. So I think those numbers and those evidences are really important to raise awareness from that perspective.
Yeah. It is awareness. And I think, lung cancer is still so intrinsically linked to smoking that, a lot of people still think it's the only cause. And, you know, obviously so much was done to raise awareness about the links of smoking and the impact that has on lung cancer as a risk factor. It's almost like we need something similar for air pollution. You know, air pollution causes lung cancer. There's been a recent study, I think came out a few months ago, about the impact of wood burning stoves and open fires and the damage that can be doing to your lungs. So it's almost like creating, you know, so having the research that's showing the people that it's being affected, but also talking about the causes and the risk factors and how that, you know, can apply to anyone.
Yeah, no, definitely. And this is the reason why also the screening criteria are always being reevaluated, because
Absolutely.
there are other risk factors, and we want to optimize, of course, a program like lung cancer screening. It's not easy, of course. I think the cigarette smoking came also with the aim of reducing the cigarette smoking, and with air pollution is a little bit more complex, as you can imagine.
Yeah, bit of a harder one to
Exactly. Exactly.
We need to breathe, so that's a bit of is an issue.
So definitely is something that is being reported, and this is also important. So has secondhand smoking, something that we didn't consider, and we are seeing now the effect, especially on women, because, of course, they were the first secondhand smokers, unfortunately. So all these other risk factors are so important to be brought up and to be published and reported. And the same is for, let's say, innate risk factors. Again, it's a little bit more, let's say, less studied compared to cigarette smoking, and I agree with you in lung cancer. But again, there are a few researchers now looking at hormonal effect especially in women in terms of risk factors, estrogen associated with more risk or not. So there are other risk factors that are being evaluated in general, because those trends that are really, really changing over the last few years should have a response in terms of an explanation. So it's very important to raise the awareness of not only cigarette smoking, unfortunately, is responsible of lung cancer. So people who did not smoke can be subject of this kind of cancer. So we need to make sure that we are doing our best to raise awareness and prevent, possibly.
Roy Castle Lung Cancer Foundation was built on the need for lung cancer research. Since 1990, we've funded millions of pounds of essential research to help people get diagnosed as soon as possible, as well as ensuring they have access to the highest quality of care. Donate now and help us fund more life-saving research. Visit roycastle.org/donate.
Mandy and I were talking before we came on air about risk calculators and things, and you talking there about, obviously, with the screening program and the risk calculators we're using, and the whole, certainly from our point of view, we see this as very much step one, and we want to, keep improving and evolving and expanding absolutely in screening. Mandy, talk about your what percentage your risk calculator generated, bearing in mind you had lung cancer at the time.
Yeah, so I had lung cancer. It was spotted on a completely unrelated scan. I won't go into too much detail because everyone's heard it 1,000 times. So they saw it. They told me to go and see a doctor. So I did. I have lung cancer in my family. My mum was actually dying of lung cancer at that time. My grandma died of lung cancer. And then I later found out that my great-grandma died of lung cancer. Anyway, besides the point, I went to see a doctor and he plugged all my statistics into a Excel spreadsheet, which I can't remember. It's 8 years ago, so I cannot remember the name of that spreadsheet. It had a formula name, and he plugged all my details in: my age, non-smoker, smoker, my weight, my height, all the good things, how much alcohol I drank, all the rest of it. And it came up with a 5% possibility that I had lung cancer. And from that alone, I'd already had a chest x-ray, so they could see that there was something there. It was very tiny. But from that 5% alone, they decided on a watch and wait for a year, and they sent me away for a year. So that's an interesting one because it was lung cancer. And there's more to the story as on when I came back the following year for an x-ray. It had grown, but because of my risk factors, they still didn't believe it was lung cancer. So they thought it might have been scar tissue, or I can't even remember the things they said it might be. And I had to make them, they couldn't biopsy it because it was too small, so I had to make them take it out, and I absolutely had to beg for it. And that took about 18 months for them to take out that little piece, which they still said wasn't lung cancer, and then 3 weeks later said it was stage 3. So that's my story, and obviously some people have similar, some people don't, but based on that calculation alone, I was sent away for a year, and then almost again for another year. So I just wonder whether, how dependent we should be on those calculators, and whether other risk factors need to be put into those calculators now, almost being brought up to date a bit. I don't know how long they've been around for, but there are a lot of people. I was lucky, really, because I wasn't stage 4. I could have been, but we speak to a lot of people in their 30s, and we've lost a lot of people in their 30s who've had a similar experience to me, but had not got anything diagnosed till they were stage 4 and too late. And that's what we're trying to avoid. It's all about early detection. So what can we do?
That's where research comes in, isn't it? So it's about, that's where research and understanding the other risk factors that then are brought into the risk calculator. That, at your point, by the time you were diagnosed, when you were diagnosed, Mandy, 8 years ago, that knowledge wasn't there. So we didn't know to ask those questions, and we didn't know to factor that into the risk score.
Absolutely.
Whereas now that's what needs to be evolving, surely.
Yeah. I feel like we need to drop, and we always say this, but we need to drop the smoking conversation, because it's really hard for a young person who hasn't smoked to have to caveat every conversation with, I had lung cancer, but I'm not a smoker. Because really, you don't deserve it whether you're a smoker or not. This is a conversation we have a lot on the podcast. But it's time that we forgot the smoking thing, in terms of, we all know smoking's bad for you, don't do it. But there is more to lung cancer than smoking.
There is.
Not forget it.
There is. Sorry to play devil's advocate, and Cecilia, please feel free to either back me up or shoot me down. But from a medical point of view, you can't ignore a smoking history, because surely
exactly.
if you've got a smoking history, then your risk is increased.
More susceptible. Absolutely.
Yeah. The smoking question comes as part of the awareness piece, and making people aware that it isn't just about smoking. But surely from a medical point of view, when you're assessing someone's risk, you can't ignore the smoke. If someone has smoked or not.
But no, you can't ignore it. I wasn't meaning that, so you're right. Sorry if it came across like that. What I mean is there are other factors which need to be just as well researched as just the smoking one, because we're seeing lots of young people with stage 4 lung cancer.
And the questions that you're asking the interviewees, Cecilia, is that gonna help kind of identify those other potential risk factors, or potentially spot some common denominators that could then lead to further investigation?
Yeah, no, definitely. I think the other risk factors, and again, I echo what you were saying in terms of smoking is still, unfortunately, the main risk factors, and is also associated with a lot of other diseases. So it's very important, of course, to make sure that we know that it's better not to smoke. That's the bottom line. But I think that, and I'm very, very confident that this will be the future in general in medicine, because even with AI, there will be some algorithm that, let's say, if you're a woman and you didn't smoke, but you have these other risk factors, even if for, let's say, an older man, these risk factors are not so important. But in that case, this will lead to a different percentage. So this kind of evolution of, again, potentially AI or helping in developing will be there. The most important thing that this algorithm should be built on the basis of numbers and research. And this is something that probably was not the case of the risk factors calculation that are still at the moment in place, because those were of probably 20 years ago. And so that's why I think it's very important to report, to publish, even in these big journals, the new statistics in terms of epidemiology, so raw statistics in terms of number of incidents, mortality, and then all the stages. And it's very reassuring that even, that the lung cancer staging has been updated every few years, because we really need to update according to epidemiology, kind of treatment, because we are changing, fortunately, the landscape of treatment for lung cancer. So we have a staging that is evolving and matching this new treatment and epidemiology. So I'm sure that also from the, let's say, pre-diagnostic, in the pre-diagnostic field, there will be an evolution that will go with this new trend, different trend. So in our research, we really aim to spot some more specific, and again, this is a UK-based research, because we really would like to know how potentially we can intervene in some population. And I'm saying population because we really want to explore also some of these stigma-related barriers. So where should we act a little bit more in depth for raising this awareness, and how those maybe mentions only few times risk factors, which we call indoor pollution, can be evaluated a little bit more, because these are also culturally different type of pollution, let's say indoor habit and then pollution. So this is where we really would like to explore more. And I know that it sometimes is not easy, because stigma is related to the fact that people is not very happy to discuss or disclose, but it's so important, because once we are overcoming this idea of lung cancer and just smoking, we can definitely have more awareness in all the fields.
The smoking question is it's so emotional, isn't it? I know, Mandy, when you were first diagnosed, you were very much making sure everyone knew you hadn't smoked, and I think it all comes down to the blame, and I'm put the inverted commas around it, because for us, no one's to blame.
There is no one to blame, but
the only people to blame actually are the tobacco companies, if we want to go down that route. But that's a whole different podcast. It's such a traumatic and alienating question, I think, that did you smoke? And I think if there are ways to change that. So the indoor pollution is a really interesting one, actually. What else would fall under indoor pollution? Would that be kind of like your open fires and things like that as well?
They have this smoky coal, or all the produce burning. And again, there are environmental scientists that are exploring a little bit more. But I feel that some of those lung cancer are not well diagnosed, so we don't know enough, because we are not getting this information. So we are definitely not collecting information about which kind of let's say burning material are you using at home. This is not a kind of question that you are doing say in hospital, so it's more on the scientific side, but it's definitely something that is reported. So especially, probably not in UK, but in low middle income countries, sometimes it's more associated, because those are the prevalent type of cooking materials as well. So I think it's very important, again, to do this kind of research on lung cancer, which was not something that we were doing before.
Fascinating.
It's about, like I said at the beginning, it's expanding our knowledge. And, we know historically lung cancer has been so underfunded. And so the majority of funding available has gone on to the biggest cohort and the biggest risk factors, which is, naturally smoking. It's really exciting and reassuring to now see all this other fantastic research that's being done beyond that, and expanding our knowledge and our scope, because it can only lead to good things. The more we understand about all the different types of risk factors, right down to that really lineal detail, that it was the holy grail, isn't it?
Yeah, sometimes I'm thinking, for example, that as soon as you are starting considering this population like young women, you're also immediately linking to these risk factors in a different way. Because even now that we were talking about burning indoor pollution, you know that, of course, cooking responsibilities are more linked to women, as we know. So this is where those kind of not cigarette-related risk factors are more prevalent.
Yeah.
The same again with late diagnosis, because young women are less keen to go to the GP or are less taken care probably. And so that's why they're going to the GP very late, and the less perceived likelihood of having lung cancer is definitely still there. But as soon as you are starting thinking about those risk factors, you're definitely linking more to different population that are not being researched before has other type of cancer. And the same, another thing that I mentioned here, but again is linked to this population, is that even post-radiotherapy from breast cancer treatment has been reported to be a risk factor for lung cancer, and so is now named under those risk factor. And again, it's important because this is something that for women was not very clear. So it's been reported, and now clinicians should know, and they know. So it's something that probably from the healthcare professional was already aware, we were already aware of, but probably from the population standpoint, from the patient standpoint, was less clear.
Yeah, that's amazing. I also read somewhere about her positive findings for lung cancer as well as breast cancer, which was something new that I read a couple of months ago, that they were associating the HER2 growth hormone with lung cancer as well as breast cancer, which is something I'd never heard. So, the research is moving very, very fast. And that was interesting from my point of view, because that was never tested when I had lung cancer, because nobody knew they were looking for it. But I subsequently had HER2 breast cancer. So, everyone said they weren't connected, but were they? I mean, you just don't know, So there are so many developments that
a lot.
And this research will only add, to the wealth of information that we're gathering. It's fantastic.
Now, this is for sure something that we need to highlight, because the evolution of lung cancer research is amazing. And in terms of on the biology side, is literally changing the landscape. Definitely on the diagnostic type of pathway, but definitely on the treatment side. So giving more and more options. So I think the future is brighter, but we need to get that diagnosis first to then give all the possible option to each patient.
It is all about that timely diagnosis, isn't it? And getting that as fast as you can. And we need to solve that. Don't know how, but we need to solve it.
There are discussion about also try to find, again, this is probably something that has not an immediate response, but share screening program for some high risk population. So again, it is a process of identifying high risk population, which would be probably the key. But having, for example, breast and lung cancer screening together may potentially save money because it will save the same person, correct? Yeah. Or for the colorectal. So there are few initial studies on that, because again, I think we should identify definitely high risk, very specific group of patients who can go through that route.
Raising awareness is key to improving early detection and eradicating stigma. Share your experience of lung cancer and help us continue to change the narrative around this disease. Get in touch through our website, roycastle.org, or message us on social.
Just talk us through kind of the logistics of the project then. So you said you're going to be doing these interviews. Just how have you done any yet? Are you still in the coordination phase? How far into the project are you?
The good news is that just yesterday we had the ethical approval, so we are ready to go, essentially. So that's the best news, because of course we spent few times in setting up the project, and essentially we are ready to invite all the participants, so patients, but also main support person and also healthcare professionals who had experience of young women with lung cancer to be interviewed. And we'll make sure the interview will be online, so we'll not use the participants' time too much. But I think, again, once we are doing the first interview, sometimes it's a very evolving process, because once you start talking about those experiences, a lot of other questions are coming up by themselves. And again, I think it's important for us to identify in the diagnostic pathway where the main gaps were and where the recurrent gaps were, because it's where possibly we can make some suggestions, let's say, or definitely some evidence in a UK setting, because it is definitely more easier for us to identify some NHS specific, let's say, barriers or facilitators, let's say. But we have also one of the co-investigator is Dr. Nargis Flores from Harvard, and she's been so kind, because she's doing this type of research since many years, and she's been also funding the first lung cancer and fertility registry, which is something very, very important for young women and any oncological disease. But of course, as you can imagine, and probably very clear from our conversation, this is something that was not considered in terms of fertility preservation in lung cancer patient, rather than, again, in breast cancer, we have a lot of opportunity project or chances to do it. So from the Flores lab, they started creating this global registry to make sure that we can have information and essentially develop a program of fertility preservation for young women who had lung cancer, because there are more and more even at younger age, so below 40.
Because that's the other part of the project, isn't it? It's about looking at the care that younger women get and need. And that is obviously a very unique aspect to them in preserving that fertility.
I think this is we call it survivorship specific needs, because survivorship is just a definition in terms of after treatment, after the initial kind of treatment, whatever it is. I think for lung cancer, we were used to have a different kind of after treatment pathway. So again, it was very difficult to have patients who did ask about, can I have the sick leave for my job? Because we had mostly retired patients. And now we're having even question about, I need to go for a school run. How can I go if I'm getting out of hospital at this time of the day? So these are needs that are definitely changing, because we are changing the population that we are seeing more often. And the fertility topic is another topic that should be offered. That's the main aim, to also the young women who are treated for lung cancer. But again, it's not the case so far.
Because we've got all these personalized, targeted treatments, haven't we? But we also need that to go hand in hand with personalized, targeted care.
Care, yes. I think this is completely different, and this is why we are aiming to interview few CNSs, because we really need those kind of perception of the need of a young woman who's been diagnosed with lung cancer, has been through possibly surgery or targeted therapy, but which specific need we need to look after a little bit more in the lung cancer community. So because this is something that is not ending after a surgical procedure or after those tablets are ending, something that will be for a long time. And fortunately, again, we're having more and more therapies that are lasting for more. So we really need to focus a little bit more. And I think that breast cancer field has given us a good example on how the survivorship care can improve the patient's quality of life for a long period of time, not only in hospital. So I think for lung cancer, we still need for young population in general, and this is not for women, I would say, is in general for young patients. We definitely need to do a little bit more. And the same, for example, I receive sometimes question about going to a flight after thoracic surgery, because this is something that we had only from patients did not have lung cancer but had other type of disease. But now, because we are operating a little bit more younger patient, we are receiving this kind of question. So again, it's making sure we are covering all the needs. We need to know the experience of those who had before this type of treatment and diagnosis, and try to improve, try to get the good examples and improve our field as well.
Yeah, it's really interesting that you mentioned kind of the flying. So the podcast last week, it was focused on robotic assisted surgery, and we had a thoracic surgeon on, and a young woman who had undergone the procedure, and she actually worked as cabin crew. So it was they thought initially they were going to have to take her whole lung because of where the tumour was, and it was going to have to be an open procedure, and that ultimately would have ended her career. But thanks to robotic assisted surgery, they were able to go in and just take half of the lung, and she, within 3 or 4 months, she was back up in the air and back flying.
Working.
So, yeah, working. Incredible. Right. Obviously, we talk about the kind of the physical support and everything, and the physical needs, but there's also the emotional support that I imagine. Well, Mandy, you tell me, because, as a young woman, a young woman to get cancer is awful. A young woman to get lung cancer, there just seems to be a bigger mental hurdle to get over that. And I think it is because of the stigma and the association with it being a male smoking related disease. I don't know, I feel like there needs to be almost like an added level of counselling and emotional support for younger women with a lung cancer diagnosis because of those perceptions of the disease and expectations.
This is my specialist subject because I need a lot of things afterwards. I think it's for me, it was a mixture of hearing lung cancer, and the first thing you think is I'm going to die. Because lung cancer had such low survival rates. We know it's different now. It's thankfully very different now and is getting better. But at that time, 8 years ago, when my mum literally had just died of lung cancer, age 68, the first thing I thought is, I'm going to die. I'm not going to be here. I'm not going to see my 50th birthday. I'm not going to be here. So that was the first thing, especially when it was stage 3. Then there's a whole stigma about smoking and having to explain and justify your illness to people that you didn't deserve. It's almost like when I went back to work and people, for very good reason, not being malicious, just like, what was wrong? And I'd say I had lung cancer. And very quickly I learned to say I had lung cancer, but I never smoked. It was one sentence. Before they had a chance to say anything about it, I'd already made the excuse for my illness. So that was really, really hard to come to terms with, because I felt like I was justifying my disease and telling them my lifestyle wasn't like that. But my mum was a smoker. So then it put an awful lot of guilt on me because of that. So I think and also I had terrible health anxiety, because after having 0 symptoms, but having stage 3 lung cancer, what else was going on in my body that I had no control over? That I was terrified. I was making plans. I've said this a few times, so forgive me. But I was going and buying myself a expensive handbag as a little treat because I deserved it, because I'm worth it. And on the way out, carrying this beautiful carrier bag, thinking, who will I leave this to in my will? That's not normal for a woman under 50 to be thinking. So this all got very, very bad in the last kind of when I was had the all clear. Within the next 6 months, it got particularly bad, and I sought counselling in the end, which completely changed my life. But I feel like there could be a level of, survivor guilt as well. Because how did I survive that? I shouldn't have. It shouldn't have been spotted, and therefore I shouldn't be here. And I still have that. So I think you're absolutely right, Rachel. The mental and emotional health part of having a cancer diagnosis needs more attention. I think it's really easy for people when you get that all clear and you ring that bell in the chemo ward and everybody cheers, all your friends gather around, or your family. It's brilliant, you've done it, you survived it, you fought it and won, all the normal things that people say. But in your head, you know that you've still got 5, maybe 8 years of checks, of scans every 6 months, of going through that every 6 months. So it doesn't feel like it's over, and that's really hard to articulate when there's no one to talk to about it, because your friends and family don't want to know that. They don't want to have that conversation. They just want to celebrate that you have done it. So yeah, sorry, that was a very long monologue. Sorry about that. But yeah, I think it's really, really important that the mental health side of it, the anxiety and the emotional part of this is covered too.
And will the interviews look at that, Cecilia, as well?
Yeah, definitely, because again, I'm a little bit biased because this is my area of research in terms of quality of life and physical and mental health. Around lung cancer diagnosis. But I think this is particularly important because in general, we should take care a little bit more of after diagnosis mental health support. Again, of course, playing the card of busy NHS and clinical psychologists are very, very busy and hard to get this referral immediately. But there should be something to, again, trigger at least the acute effect in some people. And again, regardless of age, regardless of gender, I think there is a need of looking after this aspect. So that's why the interview will focus on, of course, on these and trying to understand also where if we need to prioritize, let's say, psychosocial referral, what this should be. So is it something immediately after diagnosis? Is it after the first, let's say, part of the treatment? But it's definitely, I think, the other half of the survivorship need that we really need to investigate more.
That is music to my ears. That is so important. So thank you so much for covering that too.
I think we could carry on talking all night. I would just like to kind of ask one final question, and it's kind of, the aspiration of the project. What are you hoping to achieve, and what could it potentially lead to?
I think, again, touching on these three main aspects. So from the patient perspective, main support person perspective, and healthcare professional perspective, we really would like to know where some gaps are in terms of diagnostic pathway and survivorship pathway, because at the end, the treatment side, once you are in the, let's say, in the journey, it's okay. So regardless, of course, it's fair. So it's not about age or gender, but it's definitely before diagnosis and after diagnosis where we really need to understand more. And if we are identifying those gaps, possibly we really would like to see where we should probably investigate more. And in terms of pre-diagnostic pathway, potentially also the risk factor, as we discussed before, where the research in UK should focus a little bit more for some specific population or high-risk population. And as we just touched on the survivorship needs, where we can improve that after treatment journey for young women, and potentially explore even some method to have, for example, remote support if we are not able to have a face-to-face hospital or primary care support. Because this is the other thing. We had some research previously when I was in Leeds, and of course, lung cancer was associated with older age. And so sometimes IT literacy, so the use of smartphone or internet, was pretty much different from the same study who was investigating breast cancer patients. But in this case, we are now back to younger population with more access to, for example, smartphone or digital devices. So if this research will identify potential role of remote monitoring or even symptoms monitoring, this is something that we definitely would like to explore more.
Fantastic. Very exciting.
It is exciting, and like I said at the beginning, we're delighted to fund it because it's it's such an important piece of work, and it could make a huge difference to a lot of people moving forward. So thank you for taking the time to join us today, and thank you for taking the time to lead on this really important piece of work. And we would be delighted to have you back once you've done the interviews and you've got the information and you've identified those gaps, and we can solve this problem.
Thank you so much. No, thank you. It's been great.
Fantastic to meet you. Thank you so much.
You have been listening to Talk of Hope from Roy Castle Lung Cancer Foundation. For support and advice about any of the topics covered in this podcast, visit roycastle.org. Talk of Hope is a fortnightly podcast with new episodes released every other Tuesday. Like and subscribe to make sure you never miss an episode.